Okay, next up we have Dr. Kathy Martin. Dr. Martin received a BA in athletic training from Purdue University in 1987, her MS in physical therapy from the University of Indianapolis in 1990, and a Doctor of Health Science from the University of Indianapolis in 2013. She is currently professor and interim DPT program director at the University of Indianapolis. Her clinical background includes early intervention and inpatient pediatric general acute care. Dr. Martin has taught pediatric physical therapy at the University of Indianapolis since 2000, and her research efforts have been focused on orthotic effectiveness, and children with hypotonia. Dr. Martin is currently the chair of the Education Committee for the section on pediatrics and has been actively involved in identifying best practices in pediatric physical therapy profession education. She is also the 2008 winner of the Indiana chapter of the APTA Francis Exton Award for Outstanding Contribution to the Physical Therapy Profession. So welcome, Dr. Martin.
So since exercise is the magic bullet, everyone stand up, take a stretch break while I get my props ready. Because you've been sitting for a while. Sitting is the new smoking. You guys have heard that? All right. So stretch. All right. I would just like to say, first of all, there are several families in this room that have shared your children with me and helped me learn over the years, so thank you. Hope I can give a little bit back today. So Stephanie gave you kind of my background. I will say I've been a PT for a little over 26 years now. I got my bachelor's degree in athletic training, so after PT school, I went back to what I knew, which was athletes and sports medicine. I got involved in a therapeutic horseback riding program in my hometown. Kids set my hair on fire. Haven't looked back since. So I found out how much fun it was to work with children. I laugh every day. But I will say that it's that background in sports medicine that got me really interested in looking at foot and ankle bracing, because to me it was simple biomechanics. And that's what I had done in a clinic a lot. Was I had found great results with using just simple shoe inserts or foot orthoses, arch supports to help people with foot and ankle pain, knee pain, hip pain. And when I got started in pediatrics, it really surprised me at the number of pediatric PTs who were like freaked out by the lower extremity because, well, that's orthopedics and I don't know anything about it. No, we know a lot about it. So that was where kind of my natural interest in this area led me. And I will say that, Dr. Head gave us a great, I'll give her a shout out, talking about how exercise is protective of the brain. I've got the answer. And because that's what PTs do. We promote exercise. And one of the key messages, if you hear nothing else from me, I would love for you to know that daily physical activity needs to just be a part of your life, like brushing your teeth 2 or 3 times a day. It's just what you do. And so my talk today and my research may give you a way or a mechanism to help make that daily physical activity easier for your loved one with Down syndrome. That's my hope anyway. The other thing, why am I interested in Down syndrome? I think, okay, let's face it. I have an ego. I like to see my patients get better. And children with Down syndrome gain skill over time. And so when I see kids gaining new skills and becoming more confident, I feel like I'm a genius, right? So I feel like I've got something to offer. I really think, though, that we have something to offer for individuals with Down syndrome of all ages. And it's the adults that are the most overlooked and undertreated group. So I'm hoping, I'm starting to think about how we change that in this community, and Stephanie knows about that. But one of the first little guys I ever worked with Down syndrome, he and I were straddling a bolster. We were sitting on a bolster facing each other, and I was working on reaching tasks to work on core strength. And we were playing with a shape sorter, and he picked up one shape, and I asked him to hand it to me, and he put it behind his back and went, got a live one here. But you know what? He taught me a lot. And what he taught me was if I just figured out what motivated him and what was interesting to him, and then I worked with that, the sky was the limit. So that's part of my love for the population with Down syndrome. The other part is I have an extended family, but you're not even looking, Mandy. It's your picture. So I have a family member with Down syndrome, and she's here today. My favorite picture of you. Yes, she likes roller derby, just ask her. Okay. So in my experience working with children with Down syndrome, there are two most common options for foot and ankle bracing. For kids, it's either a supramalleolar orthosis, and the little bones on either side of your ankle are called the malleoli, hence supramalleolar. They come just above those ankle bones, or just a shoe insert, arch support, foot orthosis, whatever you want to call it. There are not very many kids that use AFOs, the ones that come up higher just below the knee. A few, but it's rare. It doesn't happen all that often. So these are the two most common options out there for young children right now. And I'll give you just a one-slide summary of here's what we know. We know that both a shoe insert or foot orthosis or an SMO, the one that comes just above the ankle, we know those work. We know those help young children with Down syndrome improve their gross motor skills, including balance, running, jumping, that kind of thing. What we don't know is when to pick the SMO or when to just pick the shoe insert. We're not really sure which kids could get away with the lesser support of just an arch support and which kids really need the SMO. We don't know that yet. We also don't really know when to start it, at what age or what developmental stage, and we also don't really know when to stop, but I'll give you some thoughts on that today. This is the orthosis that I have specifically been researching. In my studies, it's the Surestep SMO, homegrown here in Indiana. The home office is up in South Bend, Indiana. We have two branches of it here in the Indy area. There's one on the north side and one in Greenwood. So the Midwest Orthotic and Technology Company, and the owner of that company, Bernie Veldman, he developed the Surestep because he was looking for a solution for his son, who doesn't have Down syndrome but just had kind of low tone and was having a lot of foot and ankle pain playing soccer. And Bernie just kept messing around with different devices and different types of plastics and stuff until his son finally said one day, "Dad, that's it. This really works." So that's how this came about. And one of the things that I really like about the Surestep, when I first saw it, I remember thinking, oh, that's kind of cool. I like that. I didn't really understand why I liked it at the time, but it's something about it resonated with me. And I think for me, the one thing is the unique trim lines. So most orthoses come all the way to the end of the toes, like this one. So this full-length foot plate fits through the toes all the way to the end of the toes. This one does not. And the reason I think this really resonated with me as a therapist is because being able to rock up on your toes is a critical part of your balance. So if you start to lose your balance forward, you go up on your toes and your calf muscles pull you back. That's a balance reaction. So when we cut the foot plate back behind the ball of the foot, we give kids their toes back. If we give them their toes back, we let them practice their balance reactions. That's easier for them to run and easier for them to jump. Many braces that are more rigid, the brace does all the work for you. But if you allow a kid to actively use their own muscles, then they can continue to develop and get stronger. At the same time, they're taking advantage of some of the stability of the brace. So to me, this brace was really unique and something different that I hadn't seen before. And one of the things that Bernie and I have discussed this over the years, and we come up with this analogy of we're not entirely sure why it works. Let's be honest. I don't have the research data that tells you why this Surestep SMO works. One of the things I think it is because of the compression. So it's very thin and flexible. And I've got several samples if you want to see them, so you can almost crush it. And it's meant to be strapped on very tight. And that provides compression. So the analogy we've used is it's like a water bottle. If you have a fluid-filled enclosed space that's under pressure, the cap's on, the bottle doesn't collapse very easily. It's got some strength to it. But as soon as you release the pressure, better not spill this. As soon as you release the pressure, now the bottle collapses easily. So that's one of Bernie's theories, is that because you're taking the foot and ankle, think about it, it's somewhat a fluid-filled enclosed space, and you're circumferentially putting pressure on it, that you're providing some stability. The other thing that I like about this brace is that it's not rigid. When you and I walk, your foot pronates and supinates or drops in and rolls out with every single step that you take. That's normal. So why is it that we put a child in a rigid plastic brace that prevents that normal movement of pronation and supination and then expect them to walk normally? That doesn't make sense to me. That's not intuitive. So when I found a brace that does allow some movement, that made a whole lot more sense to me, that we're allowing that foot to function a little closer to normal. Many children with Down syndrome, their feet are stuck in end range of pronation. They're dropped in, and that's where they stay the whole time. What you and I do is we rotate around midline with every step that we take. So what I think the Surestep does, it gets kids out of this stuck position, brings them back to midline, and lets them function around midline. That's what you and I do. So my experience has been that this brace is very, very good, and I love it. I've also had a number of parents tell me that their child will pick up their braces off the floor in the morning and walk to the parent and hand the braces to the parent, literally asking the parent, please put these on me. There's not many medical devices we get that kind of a result. I'll never forget one little girl in my first study. I tested her in her Suresteps, and then I took these off of her to retest her in her shoes only. And boy, it's a good thing she didn't have words and that she didn't know Dr. Hahn or Dr. Chappelle yet, because she looked at me, she looked at her braces, and then she looked at me like, come on, why are you taking those away from me? So I've seen some very interesting results with these. So here's what we know. The first study I did, I looked at children who were already walking pretty well independently, put them in the Surestep, tested them right away, saw some very interesting changes within minutes of putting them in this brace. I went back 7 weeks later, tested them again, and saw even better changes. One little girl that stands out in my mind is without the Surestep, she would stop at the bottom of the stairs, look back for mom, and wait for mom and want to hold her hand before she'd attempt to go up the stairs. We put the Suresteps on her. She walked over to the stairs, grabbed the rail, and took off and never paused once or looked back at mom. And mom looked at me and said, did you see that? I'm like, yeah, I did. So there was, confidence, improved balance, and, it happened right away, and those changes got even better 7 weeks later. So and there's another young man in that study that he had probably the best motor skills that I've ever seen in a 7 or 8 year old with Down syndrome. And I remember thinking when I evaluated him, he's not going to get much out of this. He doesn't really need it. He's already got pretty good skills. He actually had the most improvement in his motor skills from the Surestep of all the kids in the study. Really made me stop and rethink this a little bit, that maybe what happened is we gave him just a little bit of stability, a little bit better awareness of where his feet were in space, and he had the voluntary motor control to take advantage of that. So here I thought, this child's already pretty good. There's going to be a ceiling effect, and wow, he really took off. So that made me stop and think, maybe we're quitting too early with some of these kids. Maybe we're taking them out of braces too early. So more on that in a minute. So these are our current questions that I'm kind of working on. I'm pretty confident in standing up here today and telling you that the Surestep works, that it helps improve gross motor skills. If it helps improve gross motor skills and confidence, it's going to help their participation in physical activity. And so that's an exercise is really the best drug out there at this point. So what we don't know is really when is the best time to start it. My current opinion, and I think the current standard of care, is that we begin putting children in some sort of foot and ankle bracing when they're first interested in being on their feet. So usually that's when they're pulling to stand, or maybe if you place them in standing, they like it and they're willing to stay there and play. That tends to be when we start introducing orthotic intervention right now. That's our current standard of care. I really have no evidence to either support or refute that, but it's kind of what's happening. When is the right time to stop using them? Well, there's no evidence for this either, but my opinion is that I would like to see individuals with Down syndrome of any age have some kind of foot and ankle support. The reason for that for me is low tone, so they have less muscular support of the foot and ankle. Ligamentous laxity, the ligaments hold the bones together. With that ligamentous laxity, there's less structural support of the foot. So if you have less structural support, less muscular support, then you have a foot that's at risk for being, for collapsing or being out of alignment, regardless of what your age is. The analogy that I've used with parents that I think resonates with many people is it's a little bit like driving your car with the front end out of alignment. You can still go. You can still get from point A to point B if your front end's out of alignment. But you're going to have some abnormal wear and tear on your tires, and they're going to wear out more quickly than they should. So putting an arch support or an SMO on an individual with Down syndrome is a little bit like aligning the front end of the car. What we're hopefully doing, theoretically what we're doing, is normalizing the forces that are going through the joints of the lower extremity. I've worked with several adult females in the late 30s, 40 range, one who'd had a total knee replacement by the time she was 40, and another who had significant reduction in her daily physical activity because of knee pain. So part of me thinks we could avoid that if we continued to provide good support. The whole body stands, was built upon the foot. If we get the foot in the proper position, we line up the foundation or align the front end, whatever analogy you want to use, then the rest of the lower extremity is going to have more normal forces going through the bones and joints. Again, no research evidence on that. That is my opinion. What I've seen after treating adults and athletes and now working with children for 20 years. So part of my, maybe thought to you is maybe we're giving up too soon, because the current standard of care is that once a child is walking well and they outgrow their current pair of braces, we stop and we don't get them another pair. Maybe that's the wrong thing to be doing. And then how much should a child wear their braces every day? Currently, physical therapists are saying, well, we want you to wear them all day. Put them on when you get up, take them off before you go to bed, 8 to 10 hours a day. Well, my studies where I've had parents track how many hours a day they've worn it, what I'm finding is I'm saying 8 to 10, and they're usually getting 6, maybe 7. And then on the weekend, it might not happen at all because they wanted to wear their nice shoes to church, or it's summertime and they wanted to wear flip-flops. And so I don't think kids are wearing braces as much as we physical therapists think they are, and yet we're still getting good results. So maybe we need to kind of rethink that, and maybe intermittent wear, where you don't wear them all day, or you save them for the most active periods of the day, and then it's okay to be barefoot in the house because being barefoot helps strengthen some of the muscles of the foot and ankle. Maybe that's okay, but we really have no data on dosage. What's the optimal number of hours a day or days per week that you should wear them? We don't know. So my current project right now is trying to get at that question of, are we stopping too soon? And with older children who already have fairly well-established gross motor skills, would they still benefit from an orthosis? And this question has been in the back of my head for about 10 or 12 years now, since I met that young man that I thought wouldn't benefit because his skills were already so good, and then he had the best benefit of any of the kids in the study. So that's been bouncing around in my head for a while. So you can see the inclusion criteria up here on the slide. I also have flyers with me. If you have a child that you think might fit this, I'd be happy to talk to you more in detail after we're done today. And I'm doing it at the University of Indianapolis, which is on the south side. You have to come see me 3 times. It'll take about an hour each time. But the Suresteps are provided to you at no cost. And I'll be doing selective measurements. I'm just looking at bodies, some anthropomorphic body size issues, and then some selected joint range of motion to try to quantify how lax or how loose the child's joints may be. And then we're just going to do gross motor skills, running, jumping, standing on one foot, walking on a line, those kind of things. But one of the things that is unique to this study that hasn't been done before is I'm going to ask you as the parent to identify 2 goals that you think bracing might help your child with, and we're going to measure progress towards those goals. And that gets at this concept of participation. So it isn't just how much range of motion does your child have, how much strength do they have, how many seconds can they stand on one foot. Who cares, right? Those are PT things. We don't care about that. What we really care about is, can your child keep up with his or her same age peers on the playground? That's what we want, right? So it's those participation, it's those parent-identified goals, and measuring whether or not we're making progress towards your goals for your child with the use of this brace. That's not been done before, and I think that's something that we as physical therapists have really overlooked. What does this mean for you and your child's life, not how many seconds can they stand on one foot? So that's been a really interesting addition to a study that I've not done before. And then the measurements will be done both with the braces and without them, trying to compare of, does the brace make a difference, or would a good supportive shoe be good enough, right? So that's why I'm looking at shoes versus just barefoot. The primary thing is, will a child still be able to get some benefit from a brace even after that point in time where they're walking well and we think we're done? So that's really the question that we're after here. I will say that not every child needs a Surestep SMO. Some may just need that arch support or the foot orthosis. And so at the last session, the parent will sit down. I'll sit down with the parent and we'll discuss your child's results. How'd they do? What do you think? Is this worthwhile to continue or not? So we'll kind of talk about it together and see if this is a good decision for your child. And then it's been mentioned today numerous times, the small sample sizes. I've had this study open for a year and a half, and I've only got 5 kids. So I realize that it's kind of a small sample, but I'd love to get more. But I'm also collaborating with a colleague in Tacoma, Washington, Dr. Julia Looper. As far as I know, she and I are the only 2 in the country researching the efficacy of foot and ankle bracing for children with Down syndrome. So we decided to do this together, and she and I are running exactly the same protocol, and then we're going to pool our data and hopefully have a little bit larger study. So please don't move to Tacoma. Stay here and be in my study. Julia and I are a little competitive about how many kids we have. So, ultimately, Julia and I both, our goal number 1 is to make sure your kids can participate, right? That they can keep up with their friends. That's what we want. But we also realize that if we can't prove that these braces help your children, you may not get third-party reimbursement for them. And we would love to be able to help you get them paid for through your insurance by being able to show that here's the data that says this works. So that's what we're after. My other study that I have going on that I have my physical therapy students involved in is based off some work from Dr. Karen Adolph, and she's not a physical therapist. She's a developmental psychologist at New York University, and she has the most amazing job. She just brings typically developing infants and toddlers into her lab, and she just sits and watches them play. And she gets paid for that. The woman's brilliant. I haven't quite figured out how to do that yet. But anyway, her work is really starting to set the pediatric physical therapist world on its ear. And it's been some very interesting data for me that has really made me rethink. It's validated much of what I've done over the years, but it's challenged me to go even further. So her data shows that that typically developing kids get massive amounts of motor skill practice every day. And for those of you who have a typically developing child around, are they not in constant motion? Do they just wear you out watching them? They're always on the move. And so this has given us some information about intensity of practice that's necessary to master a new skill. Look at this data. This depends on which study you read, but this is kind of a thumbnail sketch of what she's told us. In one waking hour, a toddler who's just learning how to walk is going to take 2,000 steps. They're going to cover 7 football fields, and they're going to fall down 15 times. That's 1 hour. So if you think about a child being awake for maybe an average of 8 hours a day, that's 16,000 steps, more than 40 football fields a day, and they're going to fall down 100 times. How many of you just could not get out of bed the next morning if that was one day of your life, right? Yeah, I can't. Thank you, Mandy. I can't even hardly get my 10,000 steps a day, and let alone 16,000. So when I look at this, it makes me think, how much practice are our children with Down syndrome getting? I suspect they're not getting nearly that much. So that's my hypothesis, is that children with Down syndrome are not moving as much. And less practice means it's going to take you a longer time to master a skill. If I could master a skill in 1 hour a week, I might be on the LPGA tour now. But, you just don't, you can't master something in 1 hour a week. So we have to find a way to help kids get more practice. So one of the things that nobody's done this yet. So I'm trying to imitate some of Dr. Adolph's studies and just watching young children with Down syndrome play to see, what do they do? And so I always ask my students this question, so what? What's the so what factor? Who cares? Well, the so what factor for me is if typically developing children require that much practice to learn how to walk, then we know that children with Down syndrome are going to need at least that much practice, but probably more because of the weakness that comes with hypotonia, the ligamentous laxity, and the more repetition that they need to master a skill. So our children with Down syndrome probably need at least that much practice and a whole lot more, and are they getting it? So the so what factor for me as a PT is I need to be helping you parents identify those opportunities for motor skill practice throughout the day so that your child is getting more practice. And ultimately, if we can help your child get more repetitions in, maybe we can speed up that process of learning how to walk. That's a theory. So this is the current project. We're videotaping kids for about 10 minutes. And then I lure my students into this project by saying you're going to improve your movement analysis skills and your observation skills. Really what they're doing is watching a videotape over and over and over till they have the whole thing memorized. But we're getting these videotapes, and then we're coding it. How much time did the child spend standing? How much time did they spend sitting? How much time were they actively moving and exploring the environment? How much time were they watching or engaging in something purposefully? And we've been doing this at Gigi's Playhouse, but I think I need to move into the home environment and get maybe a more realistic picture of that. I'll tell you why here in a moment. So these are the kids I'm looking for, kids that are experienced crawlers or novice walkers. And my IRB approval is up here shortly, and I may expand this age group because so it's not a particular age, it's a developmental stage that I'm looking for, and I may broaden that a little bit because I'm having trouble finding enough kids to do this. So again, small sample size has been a bit of a hassle. The one thing I did initially is we were filming in one room at Gigi's Playhouse, and I was thinking, because Dr. Adolph has kind of a standard set in her lab, I was thinking I needed a standardized environment. I wanted every child in the same environment. So we took a room, put the same toys in the same place every time, and the kids with Down syndrome were smarter than me because they didn't want to be in that room. All their friends were out in the gym playing, and so they kept going to the door and banging on the door and wanting out. So I've adapted my study a little bit, and now we're kind of filming in the big play space in Gigi's and trying to get a little bit more naturalistic play. But I think I would do even better if you were to allow me to come into your home and film the child playing in their environment. I probably would get a much more accurate picture of that child's motor activities. So like I say, it's a brand new study. You learn as you go, and I've made some mistakes with that, but hopefully I'm getting a better understanding how to answer this question. I will say that here's from the first 5 children in the study, it was very shocking to me. I assumed that children with Down syndrome didn't move as much. I was stunned when we got the results, and children with Down syndrome were in passive or static positions 90% of the time, and they were only actively moving about and exploring their environment 10% of the time. And that was just shocking to me. Now, I think part of that was on me, because I put them in an artificial environment and I closed the door, right? And how many kids have never met a closed door that they liked, right? So part of that's my fault, and we need to adjust the study a little bit. But I do think that children with Down syndrome are probably more passive than we realize, and we need to change this. And the physical activity piece, that's just a part of daily life. That's just what you do. So we need to change that, and we need to find ways to encourage children to move more, to get more repetitions and motor practice. So my ultimate goal with this project is to help describe what children are currently doing and then to educate parents on how to change that. So, you feeling that way right now? So yes, I could use some help. I would love to meet your kids. I would love to have more videotape for my students to watch. And so if you have any questions about, so kind of a two-pronged research agenda for me. One is the foot and ankle bracing, and in particular with the Surestep, and then this early motor development piece, and what is really going on, and can we prompt more repetition of practice every day. So please contact me if you have any questions, or if you think I have flyers about both of my studies with me if you'd like one, and then I'll just leave you with that.